Hello everyone, and welcome to my lecture on hypertension. My objectives for this lecture are for you to be able to understand the meaning and clinical significance of hypertension, to understand how to properly measure a patient's blood pressure, to define the stages of hypertension according to the most recent guidelines, to identify the types and causes of hypertension, to appropriately manage outpatient hypertension, to manage hypertension in the inpatient setting, and to manage hypertensive emergencies and the so-called hypertensive urgencies. To begin with, hypertension, or high blood pressure, is a widespread and common chronic condition that affects billions of people worldwide. The blood pressure measurements will include a systolic blood pressure, which is the maximum pressure in the aorta during a cardiac contraction, or systole, and a diastolic pressure, which is the minimum pressure in the aorta when the heart is relaxing during diastole. It's a major problem because while initially asymptomatic, high blood pressure over time will cause a number of cardiovascular changes which can lead to serious comorbid conditions such as a myocardial infarction, heart failure, stroke, renal failure, and peripheral arterial disease. So how high is too high when it comes to blood pressure? Well, this is a really controversial question because it seems that every few years or so, different studies come out that challenge the existing guidelines on blood pressure targets, and this can lead to a lot of confusion, and I'm hoping to sort that out for you in the course of this lecture. Here's a graph of blood pressure as measured in the aorta over time. We start out in the beginning of the cardiac cycle, just before the start of a contraction, pre-systole. The blood pressure is at a low of 80 millimeters of mercury. That's the diastolic pressure. The heart then contracts during systole, and that causes the pressure in the aorta to rise up to a maximum, in this case 120, which is the systolic pressure. The pressure then starts to fall up until the point where the aortic valve closes. That's the point called the dicrotic notch. At this point, the elastic recoil of the blood vessels causes the pressure to rise again briefly and then fall all the way until it reaches the low point again of 80, the diastolic pressure. You can see that in addition to the systolic and diastolic pressures, there is another pressure labeled here, the mean arterial pressure. And that's essentially a weighted average of the maximum and minimum pressures that gives you a sense of what the average pressure in the vessel is throughout the course of an entire cardiac cycle. In this next picture, we see some of the complications that can be caused by chronically elevated blood pressure, including eye problems such as blindness, strokes, heart attacks, heart failure, and renal disease. But before discussing blood pressure targets and management, we first have to be able to accurately measure our patient's blood pressure. And this can be achieved in a number of ways. The simplest and most common form that's initially taught, especially to beginning clinicians, is the manual blood pressure measurement using a device called a sphygmomanometer, or manual BP cuff. And this measurement uses the principle that turbulent blood flow through a compressed artery will generate sounds called carotid cough sounds. A pressure cuff is placed around a patient's, typically their arm, and inflated to a very high pressure, then gradually deflated. Initially, when the cuff pressure is higher than the patient's systolic blood pressure, no sounds will be heard since flow through that artery will be completely cut off. Then when the cuff pressure equals the systolic pressure, the first carotid cough sounds are audible. And when the cuff pressure equals the diastolic pressure, the sounds disappear as the vessel is no longer compressed to the point where turbulent blood flow occurs. Korotkov actually described 5 different heart sounds, 5 different blood pressure sounds, Korotkov sounds, but only the first sound, the appearance of the sounds, and the 5th sound, which is the sound of silence after the pressure drops below the diastolic pressure, are clinically relevant. This is a sample of the sounds you might hear when taking a patient's blood pressure. Hopefully you'll notice there that tapping sounds with some swooshing were heard, became louder, and gradually softened and disappeared. The point at which the sounds appeared was the systolic pressure, and the point at which the sounds disappeared was the diastolic pressure. One common pitfall when manually measuring a patient's blood pressure is a phenomenon called the auscultatory gap. This is something that occurs especially in patients with severe atherosclerotic disease, and it's associated with a disappearance of the Korotkov sounds early, followed by a reappearance of those sounds, and then a second disappearance of the sounds. In this case, the true systolic pressure was the first appearance of the sound, and the true diastolic pressure was the second disappearance of the sound. And if the clinician or person measuring the blood pressure misses the fact that there was a period of disappearance, they may wind up measuring the systolic pressure unusually low or the diastolic pressure unusually high. More recently, manual blood pressure measurements are being increasingly phased out in favor of the oscillometric, non-invasive blood pressure measuring devices, also known as the automatic BP machines. These devices also use a cuff and inflate it automatically and let it deflate. These, instead of listening for sounds, will measure small fluctuations in the pressure in the cuff over time as the cuff gets deflated, and they'll use a proprietary algorithm to convert these fluctuations into systolic and diastolic numbers. Finally, the gold standard of blood pressure measurement is the direct invasive measurement using an arterial line. This is a picture showing a sphygmomanometer, the manual blood pressure cuff, which has a pressure gauge and a bulb which is squeezed to generate pressure in the cuff, along with a valve to release pressure in the cuff. This is a oscillometric, automatic, non-invasive blood pressure machine of a type that's commonly used in our institution. In addition to a blood pressure cuff, this also has modules for measuring a patient's temperature and a device that's meant to be placed on a patient's finger, which will measure the patient's oxygen saturation and heart rate. Finally, for invasive blood pressure measurement, we have the arterial line. Catheter is placed in the patient's either femoral or radial artery, in this case the radial artery. It's connected to a pressure transducer and a pressure bag. The fluctuations in pressure are picked up by the transducer and converted into an electrical signal, which shows up as a pressure tracing on a monitor. Of course, outside of select ICU level patients, this is an impractical and often unnecessary way of measuring a patient's blood pressure. Unfortunately, studies have shown that both manual and automatic blood pressure measurements can be highly inaccurate. And one reason is that clinicians and other medical support staff often measure blood pressure incorrectly. Measurements of blood pressure should always be taken when the patient is seated, resting comfortably upright for at least 5 minutes in a quiet room without any other stressful distractions. The patient shouldn't have smoked within the past 30 minutes prior to their blood pressure recording. The size of the cuff should also be appropriate. The width of the cuff bladder should be at least 40% of the circumference of the patient's arm, and the length of the bladder should be at least 80 to 100% of the circumference of the patient's arm. During the measurement, the patient's arm should be kept manually supported to the level of their sternum. And the practitioner should take at least 2 readings in each arm, 1 minute apart, and then take the average measurement of both readings. Here's a picture showing the dimensions of the cuff that you'll need to make an appropriate measurement. So the width of the bladder from here to here. If you were to wrap this width-wise around the patient's arm circumference, it should be about half or 40% of the circumference of the patient's arm. The length of the bladder, which is the portion of the cuff that actually inflates, should be around exactly the circumference of the patient's arm or larger. So now, what are the blood pressure targets that we're aiming for? Well, in 2014, the Joint National Commission published their 8th edition guidelines on blood pressure control, and this was the JNC8. According to this, patients above 60 years of age should be controlled to a systolic blood pressure less than 150 millimeters of mercury with a diastolic less than 90 millimeters of mercury. Patients less than 60 years of age should be controlled to a systolic less than 140 with the same diastolic target. So that all patients with diabetes should be controlled to a systolic blood pressure of less than 135 to 140 millimeters of mercury, regardless of their age. So for a long time, these guidelines were widely accepted. But then in 2015, a group of clinicians across the U.S. decided that we could probably do better and perhaps even prevent a lot of cardiac comorbidities by shooting for a more strict blood pressure target. And this was the essence of the SPRINT trial, the systolic blood pressure intervention trial. And this was a multi-center study. They enrolled over 9,000 patients, and they randomized them to one of 2 arms. One was the standard treatment group, where they shot for a systolic less than 140. And then there was the intensive treatment group, where they shot for a systolic blood pressure less than 120. The outcomes they were looking for were the major cardiac comorbidities associated with blood pressure, such as myocardial infarction, any other acute coronary event, strokes, heart failure, and death from any cardiovascular cause. They include patients of all ages and patients with varying degrees of renal dysfunction. They found with their primary outcome, which was a composite of all potential cardiac comorbidities related to hypertension, the intensive treatment group did much better with a significant p-value, less than 0.001. Although it didn't seem to have a clear effect on myocardial infarction, ACS, or stroke, patients were much less likely to develop heart failure in the intensive treatment group, as well as have fewer deaths from cardiovascular and all causes. And as a result of this trial, it got the ball rolling in the direction of moving towards a more strict cutoff for blood pressure targets. And that eventually led to the 2017 guidelines published by the American College of Cardiology, ACC, and the American Heart Association, AHA. So they said that normal blood pressure was systolic less than 120 with a diastolic less than 80. For those patients, there was really not much to do, and they could be reassessed annually at their clinic visits. Patients with a systolic ranging from 120 to 129 with a diastolic less than 80 were said to have elevated blood pressure but not hypertension. These patients should be managed with lifestyle modifications alone, which we'll discuss later, and have their blood pressure reassessed more frequently, around 3 to 6 months. Patients whose systolic blood pressure was between 130 and 139, with a diastolic ranging from 80 to 89, were said to have stage 1 hypertension. These patients should have their 10-year risk of coronary cardiovascular disease assessed with a clinical prediction tool, such as the pooled cohort equations. And if they are low risk, they should be treated with lifestyle modification. And if they were higher risk, they should be started on pharmacologic therapy, one drug in addition to lifestyle modification. Stage 2 hypertension were all patients with a systolic greater than 140 or a diastolic greater than 90. And these patients were recommended to be started on 2 different pharmaceutical agents in addition to lifestyle modifications. In addition to these categories of hypertension, you described the category of white coat hypertension, which are those patients who appear to have elevated blood pressures only when measured inpatient or in an office setting with normal blood pressures at home. These patients were confirmed to have isolated white coat hypertension using ambulatory blood pressure monitoring, and many times these patients would still be started on medical therapy. The previous teaching was that these patients were unusually anxious during their clinic visits and therefore had higher blood pressure, which wouldn't be reflected in their normal relaxed blood pressure measurement at home. But the fact that these patients do develop significant blood pressure elevation in the clinic would indicate hyperadrenergic states that might point to increased risk of cardiovascular disease and would warrant intensive blood pressure treatment, even at that stage. Finally, the opposite of white coat hypertension would be masked hypertension. These are the patients who have normal office blood pressure readings but elevated blood pressure measurements with their home readings. These patients should also get ambulatory blood pressure monitoring and are often also placed on medical therapy. So why do patients become hypertensive? An important concept to keep in mind when discussing hypertension is the mean arterial pressure, as we saw before. It's given by this famous formula of mean arterial pressure minus the central venous pressure, which is often ignored since it's fairly low, is equal to the cardiac output times the systemic vascular resistance, which has to do with how the tone of the smooth muscles in the blood vessels. So a patient might be hypertensive because their cardiac output might be too high, which could be from increased heart rate, increased cardiac contractility, or increase in the cardiac preload. They could also have elevated blood pressure as a result of increase in their systemic vascular resistance, which would be caused by vasoconstriction. We classically describe two different forms of hypertension. First, there's the essential or primary hypertension, and this is often ascribed to be a combination of elevated sympathetic tone, where cardiac output increases through beta-1 stimulation of the heart, and there's increased systemic vascular resistance as a result of alpha-1 stimulation of the smooth muscles in the blood vessels. There's also increased activity of the renin-angiotensin-aldosterone system, which leads to sodium retention in the kidneys and peripheral vasoconstriction as well. The sodium retention leads to increase in the preload, which raises the cardiac output, and the vasoconstriction increases systemic vascular resistance. Finally, another major factor is decreased activity of nitric oxide, which is a natural agent that's produced in blood vessels and causes vasodilation. So lower than normal activity of nitric oxide leads to increased vascular tone. On the other hand, secondary hypertension is any hypertension that's caused by another disease process. Here's a schematic of the factors at play that cause primary hypertension or essential hypertension. These include the elevated activity of the sympathetic nervous system, the increased activity of the renin-angiotensin-aldosterone system, which leads to sodium retention and vasoconstriction, the decreased levels of nitric oxide produced in the endothelium, as well as imbalances in inflammatory factors produced by the immune system. Now, essential hypertension is very much a vicious cycle. You start with hypertension that leads to endothelial injury, which will lead to the release of vasoactive substances, decreased levels of nitric oxide, and activation of the coagulation cascade, all of which will decrease perfusion of the vital organs such as the kidney, and lead to activation of the renin-angiotensin system and the sympathetic nervous system, which will again release vasoconstrictors from the endothelium, leading to hypertension. And this hypertension will again promote endothelial injury in a cycle that is very difficult to break. Secondary causes of hypertension include renal artery atherosclerosis, which is seen in older patients with multiple cardiovascular risk factors. You'll recognize this with narrowing of the renal artery on a renal artery ultrasound. And the treatment is essentially no different than normal therapy. There's nothing specific that you would do to improve the atherosclerosis. Fibromuscular dysplasia is a variant of renal artery stenosis, typically seen in young African American females. Again, you'll see a narrowing of the renal artery on an ultrasound, but they don't typically have any other cardiovascular risk factors to suspect atherosclerosis. These patients will actually benefit from invasive interventions such as angioplasty of the stenosed renal artery. Patients who have a combination of hypertension that's difficult to control, as well as hypokalemia and a metabolic alkalosis, should be suspected to have either primary hyperaldosteronism or Conn syndrome, or the inherited genetic defect in the ENaC sodium channel in the distal collecting duct, which leads to a syndrome called Little syndrome. These can be identified and differentiated by obtaining a renin-aldosterone ratio. In primary hyperaldosteronism, the renin will typically be low, while the aldosterone level will be high. In Little syndrome, both the renin and aldosterone will be low as a result of hyperactivity in the sodium channel that aldosterone in part acts on. The treatment for these conditions include potassium-sparing diuretics such as spironolactone and amiloride. Hyperthyroidism can often be an under-recognized cause of difficult-to-control secondary hypertension. You should suspect it in particularly older patients who have unexplained atrial fibrillation, as well as diarrhea, fatigue, decreased energy, depression, and it'll be diagnosed by obtaining a TSH and free T4 levels. It's typically treated using beta blockers and a thyroid-suppressing drug such as methimazole or propylthiouracil. Coarctation of the aorta, if unrecognized in childhood, leads to secondary hypertension. It's associated with a discrepancy in the blood pressure measurements between the two arms. On a chest x-ray, you'll see the 3 sign, which is the shape formed by the coarcted aorta as it descends. Inferior rib notching, as a result of increased pressures in the subcostal arteries, can also be seen. This is typically corrected surgically. Primary hyperparathyroidism is characterized by elevated calcium levels with an increase in the intact PTH. Treatment includes surgical removal of the parathyroid glands. Polycystic kidney disease and the nephritic syndromes are also traditionally associated with difficult-to-control blood pressure. Diagnostic features would include hematuria and abnormal renal imaging showing cysts. And this doesn't have any specific treatment other than good blood pressure management. Scleroderma renal crisis is characterized by positive autoantibodies such as anti-centromere and anti-SCL70 antibodies, along with the typical features of Crest syndrome, which include calcinosis, esophageal dysmotility, scleroderma, and telangiectasia. This is one of the situations where patients with renal impairment will benefit significantly from treatment with ACE inhibitors and angiotensin receptor blockers. Obstructive sleep apnea should be suspected in patients who have reported daytime sleepiness, obesity, and snoring. They are diagnosed with a polysomnography test or sleep study, and it's treated with a CPAP machine. Pheochromocytoma should be suspected when a patient has episodic hypertension associated with headaches, palpitations, and sweating. It can be diagnosed by obtaining vanilmandylic acid levels and metanephrines. Treatment includes alpha blockers such as phentolamine and eventual surgical removal of the adrenal mass. Finally, Cushing syndrome should be suspected in patients with peripheral muscle wasting, fat redistribution, and hyperglycemia. It's diagnosed with a dexamethasone suppression test or AM cortisol level, and treatment includes surgical removal of the cortisol secreting mass and the drug aminoglutathione, which suppresses cortisol production. Now, not all patients need workup for secondary causes, but situations when you really would want to consider doing such an investigation would include patients with drug-resistant hypertension, which would be those patients who are still uncontrolled despite being on maximal doses of 3 or more primary agents. Also, you should consider this in young patients who have unexplained hypertension. patients with sudden new onset hypertension, patients who present with a hypertensive emergency, isolated diastolic hypertension in the elderly, since elderly patients typically have isolated systolic hypertension, hypertension that's associated with severe hypokalemia, in which case you should suspect hyperaldosteronism or Little syndrome. Hypertension in the elderly is a little bit unique. As I mentioned previously, elderly patients typically tend to present with elevated systolic blood pressures with normal to low diastolic blood pressures. It's typically referred to as isolated systolic hypertension. This happens because the pulse pressure, which is the difference between the systolic and diastolic pressure, is given by the stroke volume generated by the heart divided by the compliance of the blood vessels. As people age, the compliance of the blood vessels goes down, and the vessel walls become more stiff. These stiffer vessel walls reflect pressure waves generated by the heart more effectively, and these pressure waves, when they're reflected, constructively interfere with each other to raise the systolic blood pressure. So the therapies that we use specifically in the elderly are calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers, and thiazide diuretics, which particularly decrease the afterload and systolic blood pressure. Also, in elderly patients, it's a good idea to try and lower their blood pressures more slowly, looking at a reduction over a matter of weeks rather than a few days, as a result of their poor cerebral autoregulation. Since these elderly patients are especially prone to falls, you should check patients for orthostatic vital signs prior to initiating therapy, especially high-dose therapy with multiple medications. Now, lifestyle modification is recommended as first line for all stages of hypertension, and this is because it really works. So just by losing 1 kilogram over the patient's ideal body weight, they can drop their systolic blood pressure by 1 millimeter of mercury. By implementing a DASH diet rather than an unhealthy diet, they can again lower their systolic blood pressure by another 5 to 10 millimeters of mercury. By initiating an aerobic exercise regimen, if they haven't been doing any exercise before, they can again drop their blood pressure by about 5 or more millimeters of mercury. By cutting alcohol, that would drop their blood pressure by another 5 millimeters of mercury. And so, totaling all that intervention up, you can see that even without starting any pharmacologic therapy, the patient's systolic blood pressure can be lowered by 20 to 25 milliliters of mercury, which may even keep them from having to be put on medication. Here's a picture showing the components of the DASH diet. It's focused heavily on whole grains and fruits and vegetables, with only a little bit of dairy and lean protein, with a real effort made to reduce the amount of fat and sweet intake. If getting the patients to control their blood pressure just using lifestyle modifications is unsuccessful or ineffective, then we do have several options for pharmacologic therapy. The first line agents we would choose are the dihydropyridine calcium channel blockers, including amlodipine and nifedipine. Some of the benefits of choosing this class are that they do have anti-anginal properties for patients who are presenting with chest pain as well. But they do have several side effects, including worsening lower extremity edema, which can sometimes be a serious limiting factor for patient adherence, orthostatic dizziness, and a rebound tachycardia. Another class that's used first line are the thiazide diuretics. such as hydrochlorothiazide, and the newer thiazide, chlorthalidone, which is starred and bolded here because it's thought to be particularly effective as a first-line agent. This is great for patients with salt-sensitive hypertension, patients who are more volume overloaded and need increased diuretics to take some of the volume off of them. Unfortunately, it's associated with several severe side effects, including worsening urination, nocturia, which can be limiting for adherence, worsening of the patient's glycemic control, particularly bad for diabetics, hypercalcemia, and gout flares, as this does inhibit uric acid excretion. Next, there is the angiotensin-converting enzyme inhibitors, or ACE inhibitors. These would include lisinopril, enalapril, and benazepril. They're really beneficial in patients with diabetes or mild kidney disease, as they are renoprotective. But they do have some notorious side effects, including angioedema, bradykinin-induced cough, hyperkalemia, and an expected rise in creatinine of typically no more than 30% from baseline. Angiotensin receptor blockers also act on the renin-angiotensin-aldosterone system. They include agents such as losartan, valsartan, and candesartan. They're also renoprotective and are not associated with the ACE inhibitor-related cough and angioedema as significantly. Several trials have been published to compare the effectiveness of different agents in the first-line class, including the ALLHAT trial and the ACCOMPLISH trial. There were only minor differences between the first-line agents that I discussed previously, although the ALLHAT trial did show that doxazosin, an alpha blocker that was often used as a first-line agent prior to this trial, was not very effective, and as a result, alpha-1 blockers are no longer used primarily as first-line agents in hypertension, although they are still very effective in treating patients with benign prostatic hyperplasia, or BPH. Another fact to keep in mind is that the effect of a drug on blood pressure gets lower as you jump from escalating doses compared to starting a low dose of a new agent. So, for example, a patient who is on calcium channel blocker, say amlodipine 5 milligrams daily, the effect of doubling the dose to 10 milligrams daily wouldn't be as much as keeping that 5 milligrams and starting them on a low dose of an ACE inhibitor like lisinopril. Although keeping that single agent and just doubling the dose might be easier for patient adherence. In addition to the recommended first-line therapies, there are second-line therapies that are used when the first-line therapies aren't enough to control the patient's blood pressure, or the patient has other comorbid conditions that would warrant treatment with these agents. These include the beta blockers, such as carvedilol, labetalol, and nebivolol. These are the beta blockers that are most effective at reducing a patient's blood pressure. They're useful in patients who additionally, in addition to their hypertension, have angina, since they are anti-anginal, and who have arrhythmias that would require rate control, such as atrial fibrillation. They're also effective, specifically carvedilol, in patients with chronic systolic heart failure, or heart failure with reduced ejection fraction. Unfortunately, they do have multiple side effects which prevent them from being an effective first-line option. Alpha blockers, such as doxazosin and prazosin, as we previously discussed, aren't very effective in blood pressure, but have found a niche role in treating BPH. They may also be effective in treating patients whose blood pressure is related to elevated sympathetic tone, such as patients with pheochromocytoma and cocaine use. The direct arterial vasodilators, including hydralazine and minoxidil, are very effective in patients with severe kidney disease, including patients on ESRD. They are, however, known to cause rebound tachycardia and fluid retention, so they should be often given either with diuretics or to patients who are on a regular dialysis schedule. Then there are the centrally acting sympatholytics, including clonidine and alpha-methyl-dopa. Alpha-methyl-dopa is safe during pregnancy, and clonidine is often used in very refractory cases of hypertension. These aren't first-line agents generally as a result of the rebound hypertension that often occurs when a patient stops taking it abruptly. Finally, there are the aldosterone receptor antagonists, spironolactone and eplerenone. These are particularly helpful in patients with hyperaldosteronism, patients with liver failure who need additional diuretics to clear their ascites, and patients with heart failure with reduced ejection fraction, in which these drugs have mortality benefit as well. In general, we recommend that patients with diabetes and proteinuria on their urinalysis should be placed on either an ACE inhibitor or angiotensin receptor blocker. Patients with heart failure or severe LVH should be on both an ACE inhibitor or angiotensin receptor blocker and one of the evidence-based beta blockers such as carvedilol, metoprolol, or bisoprolol. Patients with a history of ischemic stroke, it's recommended that the first-line therapies would include an ACE inhibitor or ARB and a thiazide diuretic if dual therapy is needed. In pregnant women, it's not recommended at all to place the patient on ACE inhibitors or ARBs. The preferred agents have become labetalol, nifedipine, and alpha-methyl-dopa, with hydralazine sometimes used in emergencies. For aortic aneurysms, beta blockers are recommended as they reduce both the heart rate and the shear stress on the vessel wall, and this will decrease the chances of the aneurysm rupturing. Now, controlling a patient's blood pressure is a significant challenge for outpatient medicine. It's important to keep in mind that before you add on a new blood pressure medication to the medications your uncontrolled patient is already on, to confirm that the patient is actually taking the previously prescribed medications. You can do this by asking the patient directly to name their medications and ask them how they take them, to call the patient's pharmacy to make sure the patient has been actually picking up their medications, to check their pill bottles, to ask family and caregivers to confirm that the patient is taking their medications, and to ask about any side effects that the patient might be having that would be limiting their ability to stay adherent to their regimen. Think about secondary causes, including oral contraceptive pills in younger women, because just eliminating the secondary cause can help you to control blood pressure and maybe even get the patient off several medications. And as we discussed before, just simple lifestyle changes can make the difference between being on medication and not being on medication. So most patients who don't like to be on several medications can actually potentially get off of them if they make the lifestyle changes we discussed before. Moving from outpatient to inpatient hypertension, we ask the question of what you can do as a doctor when your patient acutely becomes hypertensive in the hospital while they're admitted. Well, the first thing to do is to see the patient and recheck the vital signs yourself. Make sure the blood pressure was monitored accurately in an appropriate setting. Then you'll have to ask yourself, does the patient really need emergent treatment of their blood pressure? In other words, are they having a hypertensive emergency, or do they have any other underlying comorbid conditions where blood pressure might be particularly detrimental? Those patients who are deemed to have a hypertensive emergency should often be upgraded to a more monitored setting from the medical floor and generally started on IV medications. If the patient doesn't really need emergent treatment of their blood pressure, start thinking about secondary causes. And these are different from the secondary causes of chronic hypertension, and we'll discuss those shortly. If you can't find any secondary causes, think of restarting the patient's home blood pressure medications, which we often do hold on admission for various reasons. And if there are no home blood pressure medicines to restart, consider just rechecking the patient's blood pressure in 10 to 15 minutes as the patient's increased blood pressure might have just been set off by a number of hospital triggers. It's important to keep in mind that blood pressure targets for inpatients in the hospital setting are more generous than what you would try to aim for if they were seen in an outpatient setting. So blood pressure targets, as long as they're less than 140/90, are acceptable, and you don't necessarily need to target the more strict 130/80. So some of those acute causes that you'd want to think about and address would be missed medication doses, especially beta blockers and clonidine, which are known to have rebound hypertensive effects. The effect of multiple testing and procedures that are done on the patient's NPO status, other home medications that might have been held for AKI, bradycardia, or hypertension on admission and might need to be restarted. Consider the side effects of drugs, particularly steroids, which are commonly used in the hospital, and serotonin syndrome and neuroleptic malignant syndrome, which are the result of psychiatric medications. Hypervolemia is often a cause of elevated blood pressure in the inpatient setting. We often tend to give our patients more IV fluids than they might need, or they might be renal failure patients who've missed dialysis, and all they need to get their blood pressure under control is to get the fluid out, either through diuretic use or dialysis. Very common cause of acute hypertension in the inpatient setting is anxiety, pain, and acute delirium. Withdrawal from recreational drugs, including alcohol and opiates, can also make a patient very agitated, anxious, and hypertensive. Acute strokes and elevated intracranial pressures as part of the Cushing's reflex may actually be one of your first clues that the patient is actually having a neurologic emergency. Malignant hyperthermia, seen as a result of anesthesia use in a patient who recently had a procedure. And a pheochromocytoma manifesting with episodic hypertension. It's important not to be too aggressive with controlling a patient's blood pressure, particularly in the acute inpatient setting, largely as a result of a process called cerebral autoregulation. Here's a graph showing how the brain responds to different blood pressures, different mean arterial pressures, and tries to maintain a constant cerebral blood flow over a range of different mean arterial pressures. The blood vessels supplying the brain do this by regulating the degree of vasoconstriction or vasodilation in response to a wide range of changes in the mean arterial pressure. Hypertensive patients, chronically hypertensive patients, tolerate a much higher range of mean arterial pressures compared to the normotensive patients. Their brains more effectively perfuse at the higher pressures. So if you were to acutely lower a patient whose blood pressure had been chronically sitting around 200 all the way down to a mean arterial pressure of 100, there would be a significant decrease in their cerebral blood flow. And so it's important not to lower it too much and too quickly. So whenever lowering the blood pressure, we need to balance the risks of them being at a higher blood pressure, which would include things like hemorrhagic stroke, with the risk of hyperperfusing the brain and causing an ischemic stroke. So in order to properly manage inpatient hypertension, you have to be able to recognize when your patient is in a hypertensive emergency. Hypertensive emergency is any episode of significant hypertension associated with acute end-organ damage. And by end-organ damage, we're referring to specific abnormalities in several key organs. First would be the neurologic system, where you could see emergencies manifesting as altered mental status, acute vision changes, seizures, and new strokes or hemorrhages seen on a CAT scan. In the eye, you'll also see vision changes. You'll look for evidence of papilledema, cotton wool spots, AV nicking, and flame hemorrhages. In the heart, you'll look for symptoms of and signs of heart failure, symptoms of anginal chest pain, elevation in the troponin, and characteristic ECG changes suggestive of ischemia. In the lung, you'll listen for new crackles, ask about symptoms of acute dyspnea, and look for new chest X-ray infiltrates suggestive of acute pulmonary edema. And in the renal system, you'll ask about changes in urine output, measure it, look for oliguria, check for new AKI or presence of hematuria. Here's some fundoscopic images that you would use to recognize emergencies in your patient. First, here's an image showing blurring of the optic disc margins, and that's indicative of elevated intraocular pressure, which is compressing the optic nerve. It's called papilledema. This fundoscopic exam has a spot here indicated by the arrow that's white. This is the cotton wool spot, and it's indicating axonal injury as a result of hypertension. In this image, we see a bright red artery crossing a dark red vein. As the artery crosses the vein, it squishes the vein a little bit, so you'll see a little narrowing just where the artery is crossing, and that's the phenomenon of AV nicking. It's caused by a significant increase in the pressure in this artery compared to the vein, which is actually enough to compress the vein and block flow. Finally, in this fundoscopic exam, we see dark splotches, which are the flame hemorrhages caused by severe hypertension. So looking for any of these physical exam findings will allow you to identify a patient with hypertensive emergency. Patients who are particularly hypertensive, typically the cutoff is given of systolic greater than 180 with a diastolic greater than 110, but who do not have evidence of end-organ injury are said to be in a hypertensive urgency. This is better termed severe asymptomatic hypertension, since the term hypertensive urgency implies that you do need to act quickly to lower their blood pressure, which may not be the case. So most patients with systolic greater than 180 or diastolic greater than 110, 120 don't need emergent treatment. But in certain patients, you may want to consider trying to lower their blood pressure more quickly. These are the patients with chronic heart failure and at high risk for decompensation, because the increased afterload caused by the hypertension might set them off into an exacerbation. Patients with a history of severe mitral regurgitation, aortic stenosis, or hypertrophic obstructive cardiomyopathy. Again, these are patients where increased afterload can be very detrimental to their hemodynamic function. Patients with known intracranial or aortic aneurysm, in which case the significant increase in blood pressure might make those conditions more likely to rupture and lead to life-threatening emergencies. Patients with active coronary disease, and patients with history of a stroke. Although not technically considered in indication for urgent intervention, sometimes when hypertension is holding up a patient's discharge, you may want to consider giving them a rapid-acting dose of blood pressure medication. But most of the other patients don't really require any additional treatment beyond adjustment of their PO antihypertensive regimen. Particularly in our most critically ill patients, we tend to avoid starting them on standing hypertensive medications, especially oral agents, and we'll often just give them IV pushes as needed to control their blood pressure less than 180 systolic. For those patients who you'd classify as having a hypertensive urgency and need have the indications for urgent treatment, you would generally choose PO oral agents that are rapidly acting. Some of your options include extended release nifedipine, carvedilol, labetalol, clonidine, captopril, the ACE inhibitor, or hydralazine, and furosemide. The doses and the indications and contraindications for each of these are given in the chart. For patients with hypertensive emergencies, there is a preference for IV agents that are rapidly acting, and these are given in the chart below. Nitroprusside is a direct arterial vasodilator. It's preferred to be used in ICU patients, particularly with cardiac conditions such as acute heart failure, mitral regurgitation, aortic regurgitation, or a ventricular septal defect, as the reduction in cardiac preload does, cardiac afterload does decrease the workload on the heart and help direct increased forward flow through the aortic valve. Historical concern in the use of nitroprusside is cyanide toxicity, since the nitroprusside molecule does contain multiple cyanide groups. Nitroglycerin, often given as an IV infusion, is a very common drug that's preferred in patients who present with anginal pain and hypertension, or hypertension associated with acute decompensated heart failure. It's very easily titratable. Its biggest limitation is tachyphylaxis, which means that 24 to 48 hours after starting an infusion of nitroglycerin, it needs to be transitioned to PO therapy, as it quickly loses its effectiveness over time. Nicardipine, or Cardine, is an IV calcium channel blocker that's effective, especially effective for patients who present with neurologic emergencies such as an acute stroke, particularly in acute ischemic stroke where the patient is a TPA candidate and their blood pressure needs to be acutely lowered in order to allow them to take TPA. Labetalol is an alpha nonspecific beta blocker, which can be given as an IV push or an IV infusion. It's particularly effective in patients with aortic dissection as it lowers their heart rate and cardiac output, reducing the shear stress on the aorta. Also effective in pregnancy, where it's considered relatively safe, and a thyroid storm. With all beta blockers, it's to be used with caution in patients with bronchospasm, bradycardia, and AV block. IV enalapril, or naliprolat, is a ACE inhibitor class drug, which is actually a precursor to the PO agent enalapril. And it's particularly effective in patients who present with a scleroderma renal crisis with hypertension or hypertension associated with a acute decompensated heart failure. Finally, phenoldiprem is a dopamine receptor agonist, which is especially effective in preserving perfusion to the kidneys. So in general, these first two agents are helpful in cardiac emergencies. These two agents are particularly effective in neurologic emergencies. Phenoldiprem is particularly effective when the primary emergency is with the kidney. And IV enalapril is helpful specifically in the renal emergency of scleroderma renal crisis and in cardiac emergencies, specifically acute heart failure. When addressing a hypertensive emergency, it's important to lower the mean arterial pressure by no more than 25% in the first couple of hours, and then try to reach a normal baseline over the first 24 hours. And this is primarily done as a result of the brain's cerebral autoregulation in order to prevent the cerebral blood flow from dropping too quickly and causing ischemia to the brain. As we see here, cardiac emergencies are best handled with nitroglycerin, and neurologic emergencies are often best handled with nicardipine. And if the hypertensive emergency is thought to be related to elevated sympathetic tone, choose a beta blocker such as labetalol. Certain special situations include patients with acute hypertension in the setting of an acute ischemic stroke. In these patients, if TPA is being planned, aim to lower their blood pressure to less than 185 over 110 prior to the administration of TPA, and aim to control it to less than 180 over 105 while the TPA is running. Patients who are not candidates for TPA should have a more liberal target of less than 220 or 120 for the first 24 to 48 hours. That's called permissive hypertension, and it helps to maximize blood flow to the ischemic penumbra around the infarcted brain tissue and keep it from dying along with the core infarcted brain tissue. In an acute hemorrhagic stroke, the goal is to lower the systolic pressure to around 140 to 160, not to drop it too low or to keep it too high, with a goal mean arterial pressure of 100 to 120. In an aortic dissection, the goal, as I previously mentioned, is to limit the shear stress on the aortic wall, and you do that by lowering the systolic blood pressure to 100 to 120 with a heart rate as low as possibly tolerated, typically 50 to 60 beats per minute. The best agent for that would be labetalol and esmolol, short-acting beta blockers, with nitroprusside as an adjunct. In summary, according to the 2017 guidelines, the newest ACC/AHA guidelines, blood pressures above 130/180 are considered to be hypertension, regardless of the patient's age. Blood pressure measurements should always be made appropriately in accordance with best practices to ensure that the patient is getting the appropriate management. Essential hypertension is due to primary derangements in the patient's renin-angiotensin-aldosterone and sympathetic nervous systems, whereas secondary cause of hypertension should always be investigated in patients with any suspicious features. The first-line therapies for chronic hypertension include lifestyle changes, ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazide diuretics. Most inpatients with hypertension and who do not have any concerning acute symptoms don't need emergent treatment, especially not with IV agents. And patients who do have features that are suggestive of hypertensive emergency with acute end organ dysfunction need to be closely monitored and started on IV medications. And that concludes my lecture on hypertension. I hope you enjoyed and have a great day.